Um, Thank you. We're very excited. We do have others in the room with us, so our owl might pick them up at some point. We do want to go ahead and get started. It is just a little bit after 5. If you don't know me, I'm Judy Drake, Human Resource Manager for the Town of Ithaca and Chair of the Health Consortium. So I would like to introduce a few people because some may not know our new clerk of the board, Lynn Sheldon. I don't know if Lynn's. You may see her on another soon. I guess I'm not going to pick up. So welcome, Lynn. We're very excited to have Lynn working with us. I guess I'm not going to go around the room as we have new representatives, but hopefully you'll see pictures.
If you want, John can move the camera.
Okay.
Where are you starting?
Why don't we start with Kate? Keep going. And we have Angela Conger from Village of Groton and Nancy Funder from Village of Groton. Let's see, we have Mary Ellen from Town of Lansing in back. We have Mark, can't see that far away. And we have Lynn Way in back. Kind of can see her. Okay, and then of course, our rest of our staff, we have Terry, who is our finance manager, and Kylie, who is our benefit specialist, and of course, Elon. So that's who's in the room with us. So welcome. I am going to just give a quick update from where we are at on our strategic planning, our long-term business planning update. The executive committee has broken up into a smaller group to start looking at some long-term business planning. Some things that we have been focusing on is still, focusing on maintaining our mission and our vision, and that's our core. Some of the topics that we've been talking about is growth, number of municipalities, number of participants, and then also number of employees, retirees, that kind of stuff. And then how fast do we want to grow over time? So that's been a heavy topic. One of the things that's also going to relate to our speaker today is risk and how we look at risk from our reserves, how much we have in our reserves, our fund balance after reserving, and then of course our high claims and the impact that high claims have on us every year on our stop loss. Another topic has been our plans, our plan design, the number of plans, what are we offering? Can we reduce some of the number of plans as the participants on them decrease? Medicare and Medicare Advantage that Kylie will be speaking a little bit more about later, and Elin. And then of course our premium rates is always a very important aspect of that. And Elin's going to talk more about a lot of that later on. So without further ado, I'd like to present our speaker. Today we have the Senior Vice President of the Health Plan Finance Officer for Excellus Health Plan. And Bob is going to be speaking to us about risk. So I will turn it over to Bob.
I believe I'm unmuted. I appreciate that. Thank you all for having me. I'm really happy to be here. Quick background. I think everyone got a bio in their packet, but I've been with the organization with Excellus for 19 years, all of which in finance, and then prior to that was in a health system for about 7 years. I'm responsible for all of the commercial business, the government program business, everything we do as a health plan, as well as some of our subsidiaries, etc. I'm going to talk a bit about today about your reserves and what you have, how we think about them as a health plan. We'll talk about some growth and risk mitigation. Please ask me questions as if you will, during the presentation. I'd be happy to answer those on the fly. I'll try to integrate some considerations. I'm thinking you're going to share the deck, so there we go. Perfect. I will, I'll cue us as we go along. And I'll kind of jump right into it. Our first slide, the next slide, please. Quick disclosure, did have some actuaries help me with some work behind the scenes on evaluating here. So quick disclosure, you know, I'm not here to give you actuarial advice. You have a great team of consultants that do that. I'm just here to add some Excelis perspective to the work that you guys already do as an organization. So quick disclosure, no need to read through that from my perspective. So we'll talk about your claim reserves, the value of reserving, have some open discussion, talk about, you know, the way the cooperative reserves is very similar to the way at the health plan we think about reserves. We have some broader spectrum reserves because of the different types of business we're in, and I'll kind of highlight a few of those uniquenesses. But we'll talk through each of yours, whether, you know, in general opinion, you know, how well you're reserved, and I think you're doing all the right things, and what you need to consider as you grow and things of that nature. So I'll make sure I bring in that health plan perspective. You know, you should, again, feel free to ask questions how they relate, and I'd be happy to answer now, you know, as we go or at the end. Next slide, please. Next one, intro. So here are your claim reserves for the cooperative. I'll take them across and then we'll kind of dive into each of them individually. Your IBNR, which stands for incurred but not reported. These are your claims that have happened out in the community. Maybe folks that are in the hospital or have had a claim but has not come through and paid yet. That's a state regulated reserve, so we'll go into some detail. Another surplus is another state regulated reserve, about 5% on that. Rate stabilization. This is really designed to smooth your rate changes over time. As you use this, you do have to replenish it. So there is kind of a, you know, you want to make sure you keep that. That is an optional reserve. We'll talk about, you know, like the risk there and is that enough or not. Leading the finance of the health plan, my job is to mitigate our risk and to manage that risk. And, you know, if anything, we lean a little heavier on reserves. And you know, as you grow, those are some of the things you're going to want to make sure, you know, you're leaning in on. I'm not sure there's such thing as over reserving. So, you know, our default position is going to be conservatism. I think you are appropriately reserved, you know, generically speaking, but I wouldn't say over reserved. And that's, you know, something you always want to be monitoring, especially as you grow. Your catastrophic claim reserve. This is your reserve you use to cover the kind of, I'm going to call it the high cost that is between a normal claim, you know, a certain threshold up to the point that stop loss comes into play. You have stop loss at $1 million. We'll talk in detail about, you know, the risk there. That's a relatively high stop loss attachment point, but I think you've got a good reserve to help cover your gap between, you know, normal claim volume and that $1 million catastrophic claim. And then we'll briefly touch on the advanced deposits that Excelis holds and why that's required by us as an insurance company. You know, these numbers, we have 4 columns of numbers. I focused our conversation on the last column, but these are numbers you might have seen. Your adopted budget, amended budget, year to date through July, and then your actuals at the end. I focused on the actuals. I know you don't chew these up till about a year after your plan year ends. But I just want to make sure, you know, we shared, you know, this is what we had, and you might have seen these numbers as you've done your work over time. Let's dive into the next slide, which is the incurred but not reported reserve. As you know, you're in Article 47. DFS regulates your entity very much like they regulate us as an insurance company. So DFS requires us to have a certain amount of reserves on hand. Theirs are usually low water marks, which means if you're meeting their requirements, they want to protect your solvency. That's the goal of the regulator here. So very much in Article 47, the same as the health plan, they want to protect solvency. We in the health plan view our minimum requirements exactly as such, minimum requirements, and we are trying to be higher than that. As a branding entity with Blue Cross Blue Shield, the association that we get that brand from has higher reserve requirements than DFS does. So we have to manage to multiple guidelines here. The general rule here is it should not be less than 25%. That's a bit dated. You have approval to be down at 12%. I believe you're the lowest cooperative approval here. Most everyone else is at 17% incurred claims. You know, you'll see this note here at 12% of incurred reserve level, reserves will be insufficient 1 out of 100 valuations. So when we look at the history and the distribution of variation here, we're saying that in 99% of the time, this 12% reserve is going to be sufficient to pay the claims that you have outstanding. I would say that's the right reserve level. So even though you're below the average of 17, I would say you should feel comfortable that you're reserving the right amount. Now, again, there's the chance that you exceed that reserve, but there's a very low percentage chance here. So you're probably managing your risk. This is an item that's governed by the state. You can reserve more, you can't reserve less. So that's that's kind of the really good point here. And you've got approval for your 12. I think I saw a question pop up in chat. Let me take a peek. How can growth be a double-edged sword? Large chunks increase revenue percentage. Yep, that's very true. As you grow, I'd say this: the larger the better when it comes to risk mitigation as a general rule. Now, you do stand that risk of picking up some catastrophic members, especially as you grow. I'm assuming a lot of your growth is going to be through small, what I would call small group, under 100 eligible employees. So you're going to be getting folks who don't necessarily know what their experience is from an experience rated quote. You're going to be kind of taking them in a less knowledgeable way. That's a reality you have to work with. You do want to do as much evaluation around, what is their benefit structure, or, do they have benefit designs that are going to, encourage overutilization or underutilization and things of that nature. So you do want to make sure you're evaluating folks that are coming in, but as a general rule, larger is going to be better for spreading risk. I mentioned, and I'll talk about it a little bit in your high claim, you want to be able to have enough reserves to withstand variation that's going to happen. The smaller the group, the more variation that happens. In our company, we would say the smallest group that we evaluate as a standalone set of folks is about 25,000 folks, and that's still a moderately volatile population. That's our individual market for New York State, where folks are buying individual direct coverage. That's pretty volatile population, and we add some extra risk charges in for that so that we can cover the variation that happens. The lowest level of credibility, I would say, where the population starts to be credible on itself with both trends and experience, is about the 10,000 member mark. You're still pretty far shy of that, so I would say growing towards that number is good for the organization. You do always have that risk of picking up some negative risk, but as a general rule, growth is favorable. Hope I answered that question. I will take us into the next slide, please. Here is your surplus. Again, New York State law requires a reserve and surplus requirements of 5% of your earned premium. So as you grow in premium, these reserves and dollar value are both going to naturally grow because they're a percentage of earned premium. That will also give you some earnings on those reserves. I didn't really mention that in the beginning. But as you have reserves, we rely in the health plan for our reserves to generate some investment income that helps subsidize some of our insurance rates. That is typical of insurance companies. You're growing your reserves so that you're generating investment incomes so that when you have downturns, you have some supplemental income coming in to help offset rate variation. Excuse me. Municipal cooperatives have a plan that consists of 5 or more participating are required to have this reserve. So this is required by New York State law. There's not a lot of volatility. That's your minimum of 5%. You're at 2.7 million as required by the state. You can see smaller entities are required to hold an extra 2% into this reserves. So again, think of that 5% as your minimum. Anything you can do above that is going to be favorable for protecting you against variation and your solvency in the organization. So another one that is, there's not a lot of debate on these. These are state governed, but you're in a good place in these categories. I will move on to the next slide. Now, rate stabilization, here's where you have reserves that have a little more, self-consideration here. Catastrophic, we would call this catastrophic claim reserves, intended to set aside funds for unforeseen future increases and to smooth rates over time. Population of about 6,000 is going to have some claim experience variation year to year. High claimants are going to move those numbers. Higher volumes of moderate sized claims. So, the folks that are in the $100,000 to $200,000 range can move your premiums. Generally, folks want to have a rate stabilization reserve that can help smooth that. So in 1 year, you don't have a spike of 12 or a trough of 2. You want to be able to soften the higher increases in your premium. And then on the years where you have a lower rate increase required in your premium, that's where you replenish these reserves. So you want to use these to balance increases over time. In the health plan, we don't necessarily carry a rate stabilization reserve. However, we rely on our reserves to stabilize rates, because if we have a really poor performing experience rated year, we know we can't raise rates to recover those dollars in the next year. The market will not tolerate that. So we'll do things like smooth that rate, take a little bit of a loss maybe in that year so that next year we can recover. And so it helps us smooth rates for our customers over time. The cooperative uses this in the same way. This is really valuable. Again, the last bullet there, when spending a rate stabilization down, you do need to embed some dollars in future premium to refund, if you will, that rate stabilization reserve. You want to make sure it's in hand when you need it, because if you spend it down and don't replenish it, then you've kind of lost the function. Just want to share one experience here. We have a very large customer who leverages a rate stabilization fund that we manage with them. They spent down 20% surplus. So they had $40 million in a rate stabilization fund, which represented 20%. So, basically triple what you're carrying almost. And they had such bad experience year over year. They spent that entire $40 million or 20% down over a 2.5-year period, smoothing their rates. Now, so I just want to give that example of experience can swing pretty significantly, and these reserves will help protect you against that. I'm not suggesting the cooperative needs a 20% reserve here, but know that it can move in a given year pretty substantially to chew up that full rate stabilization reserve you have. You need to be able to make sure you're planning for how do you replenish if you have 2 years in a row of really high experience, and you're paying directly for your experience. So these are factors you have to consider within your own cooperative here. I'll pause there for a minute in case anyone has a question there. I tend to move at a good clip, so pausing is helpful for me to slow down and give you an opportunity. Okay, I will move along then. Here we took a look at book trend and variation. When we reviewed the year-to-year claim fluctuations we see in groups of similar size, we model that against our pool. What we see is about 20% of the time. Oh, I'm sorry. Yes. You're like, nope, no audio question. Okay, maybe just a mute there. About 20% of the time, so 1 in 5 years, this 7.5% is going to be insufficient from the average. So if you're trying to maintain an average rate increase, and for us, if I take average and make it 0, meaning that's the average rate increase and it's your variation from there, about 20% of the time, it's more than 7.5% different than the average on a group of your size. So you do have to plan for this. This is one that if I was, running our organization and I operated this individual reserve, I would feel like I would want some more protection here. But this, 80% of the time being sufficient is also a good place to be. But as I said, I lean in on conservative views here from that perspective. Make sure that settles with everybody. RSR, meaning rate stabilization reserve, just acronym in there. Make sure we are clear. Okay. Now catastrophic claims. The other item we did was look at our catastrophic claim reserve. Excuse me. You have 4.7 million. You have some methodology that's approved by the board that your consulting group shared with us. You have $1 million, bullets on the right, $1 million stop loss policy. So stop loss, for folks that aren't close to that, that's an insurance policy you buy that helps cover the dollars that are in excess of $1 million. So think of this as an insurance policy that has a $1 million deductible at a member level. That's a fairly high stop loss. We have a couple groups that are tens of thousands of members that buy stop loss at the $1 million mark. You're doing the right thing by having this catastrophic claim coverage reserve within your reserve portfolio as well. When we look at your catastrophic claim reserve, expect to be 4.5 million stop loss claimants in a given year. We looked at the Milliman. Milliman is a actuarial consulting firm. We buy cost guidelines from them in order to evaluate the way we reserve and the way we do our business. When we look at their cost guidelines, they suggest that a group of your size, 6,400 members, is going to have 4.2 members greater than $1 million. So when we look at that and we look at where you're reserving here, you're in a pretty good place. Now, your catastrophic claim reserve covers, I have the note here somewhere, but I think covers from 500,000 up to the $1 million threshold. Because that is a high claimant. I would say anything in a group of 6,000, I think of a high claimant somewhere over 500,000. You're insuring that in two ways, with your catastrophic claim reserve and then the excess claim coverage that you have through stop loss. This is a place where growth is another area where you don't necessarily know this as you grow, but this is where you can potentially pick up a single member that has some catastrophic claims. To give you the risk, we had a single member we have about 1.5 million members that Excelis is either the administrator for or insures. To give you kind of the far end of the pendulum swing here, we had a single member who was averaging $1 million a month for nearly 2 years. So a $24 million spend on a single individual in a 24-month period. Significant. That's unusual, very unusual. We have not seen that repeat itself, but that kind of gives you the extreme of an individual claimant can happen. There is a lot more as technology advances and procedures advance. The claimants above $1 million have really continued to advance. In our small group portfolio, so our small group population is about 172,000 members, so very stable, large population. Over post-COVID, we saw our high claimant population double because of delayed treatment and delayed care. So those are things as an insurance company, we pay a lot of attention to, that folks during the pandemic were not getting their preventative care, we're not getting their screenings, we're potentially catching illnesses later stages. Think of it as cancer that's not a stage 1 that advanced to a stage 2 or a stage 3. So those conditions end up being a lot further along than they would have been during a normal year. And those are resulting in higher claimants than we expected in the last couple of years, like kind of in 21 into 22. And I would expect that to persist. For example, we know some of the gastroenterology groups that are doing colonoscopies are over a year behind in their ability to schedule, that if you call today and schedule, they're backed up significantly. A year delay of catching a condition can be fairly significant. So this is I would pay close attention to how well this is performing. And I think annually you evaluate the growth of this reserve. But this is, I think you're in a good space here, doing the right thing, having specific reserves for these high claimants to cover your gap between, day-to-day average claims and your high claimant stop loss policy that you purchase. Okay. Advanced deposits. Here, this is just cash. We have the Excelis Health Plan holds 700, and I think this just got updated, but about 800,000 in cash advance. Just a quick operational detail here. Excelis pays providers prior to billing its customers, like the cooperative, for their claims. So we'll pay weekly. We then invoice self-funded customers like yourself. And then we collect about, almost 2 weeks later from when the payments are paid and incurred. DFS requires us that we can't use insured premiums to pay for claims, and so we require a cash advance to front load those. We do get some advantage with our providers from paying those in advance. This helps us in our negotiations and our provider rates, that they know they're not waiting on payments from self-funded customers. So this adds some value to our providers, which allows us to have a good broad network to prepay and not wait until we collect to pay them. So while I know sometimes this is a point of question of why do we have to give you cash before we have claims, remember we've outlaid cash for about a week and a half worth of claims prior to collecting money from our customers. This helps us cover that gap. You're at a 1 week advance pay. That's our lowest level that will allow our customers to have. We default to 2. Larger customers like yourselves with longstanding history of good payments, etc. We'll knock down to 1 week, which is where the cooperative is at. I just want to make sure I hit some of the other things. I'll just talk about maybe from a health plan perspective that we think about when we do our broader reserves. Things like what's going to happen with COVID vaccines as new regulations and new requirements come out. The idea that health plans have to cover over-the-counter vaccines, that was never an item that we had to cover in the past. So those can be meaningful on large populations. We think about pay cycles. If there's holidays on Mondays are always our biggest pay cycle for procedures. And if there's a holiday on a Monday, that suppresses a monthly payment in a way that is fairly meaningful. I'm not suggesting you're evaluating your reserves on a monthly basis, but at the health plan, we're evaluating our reserving every single month, evaluating what's in our IBNR and calculating that. We have, vaccine changes. Who's going to get vaccines? Is that going to change? We have disenrollment reserves. We have lots of different things that are impacted as a health plan that you as just a sponsored health plan don't need to worry about. But reserving is a big portion of how we manage our risk, understanding what the future holds, and making sure that we have reserves to cover changes that are going to happen or we expect to happen in coming years from regulators, from member behavior, usage changes, etc. I will pause here. I think we're kind of right on time. You allotted me about 30 minutes and we're at about 27 or so minutes. I want to make sure I'm cognizant of that. This is, you can flip to the next slide. I think it says questions, if I'm correct. Yep, there we go. I'd welcome any questions or concerns folks might have.
Bob?
Yes.
One of the questions, hi Bob, this is Elin.
Hey.
One of the questions we keep getting asked is, you were talking about COVID vaccines and kind of planning for the future. You were also talking about the backup in colonoscopies and the cost that comes along with that. As we look at coming out of the pandemic and a lot of the money that was lost to providers, as Excellus is negotiating with our providers, what is Excellus seeing as far as provider costs going up in the future relative to recovering from the pandemic?
Yeah, good, great question and a big topic of conversation with us. So we have, I wouldn't describe our negotiations with our providers as used car buying, if you will, but there's always a negotiation point of the ask and the final price, if you will. I will say that providers are asking for larger numbers in the current year than we've seen. A big portion of this is the traveling nurses. I'm sure many of you have seen in the news or in different spaces that nursing costs are in some cases triple their normal cycle of nursing costs in a given year. We are having a lot of asks from providers. In most cases, we're pushing back hard there, right? Because anything we agree to, our self-funded customers have to shoulder the bill. Our insured customers will have to pay that in premium. We've not priced for those things in prior years. We're make sure that we're holding the line and saying to our providers, let us help you go sometimes to the state and try to get funding there, because these are kind of cliff issues versus long-term changes of cost structure. We think that as employment levels start to change, that employment market will change, and so will the nursing costs. But we are definitely getting higher asks than we've had in any recent memory for particularly our hospitals. The other unique thing that's happening in hospitals is there's a lot of nursing home folks that are stuck in hospitals that they can't discharge to nursing homes because nursing homes can't get staff, and they now have staffing levels that the state required. So if they can't hire staff, they can't take admissions from the hospital, which is where most of their admissions come. So now hospital beds are filled with lower intensity patients. So they get more like a nursing home rate when that lower intensity person is in the hospital. And so hospitals can't do the elective procedures and other things that is really where they generate their margins to cover the negative margin on those low intensity services. So the system itself is still in a bit of upheaval in how it functions. And I would say we're still more than a year away from letting that settle out and having hospitals and nursing homes and preventive care kind of true up back to their normal cycle. There are some good things that came out of this, like ER utilization has decreased. Some of the high cost care has gone out. More services have moved to outpatient care. So we've seen outpatient costs go up. But really think about that as, even though as you see some reporting, it might show outpatient costs elevating, that is really a shift from inpatient to outpatient. And so those services can often be done more effectively, more efficiently at an outpatient surgery center. So those are the types of things. There's still a lot of flux, Elin, and we'll continue to monitor that and can keep you abreast as we progress. Hope that was helpful.
That's helpful, thank you. I have a second question, follow-up question for you. Kylie and I, and I'm not asking for the long answer on this, Kylie and I attended our first webinar today on the Inflation Reduction Act. So I know we're still unraveling all the ramifications of that act, but from what Excelis knows and what information you've been able to ascertain about the changes in that law, how much of the expense of that act will be put on us as a self-funded insurance organization, versus subsidies from the government? Where do you think that balance will be when it comes to mandated costs of prescription drugs and other care?
Yeah, that's a great question. We are unraveling, as you said, as you are. A lot of that is in the Medicare prescription drug space coverage. So this is a pretty big enhancement to that coverage. The question is what funding will be there, and we're kind of working through with our regulators right now on that space. I would say we'll come back to you when we know more, but there's some significant coverage improvements in coverage for seniors. That's going to be notable, and whether that is going to come through CMS funding or employer group funding, excuse me, that's kind of to be seen and still to be worked out. I'll maybe touch on one item you didn't there, which is like the right for CMS to negotiate with drug prices. Inevitably, when government pricing for things like drug go down, then commercial prices go up. Pharmaceutical companies are strong in their lobbying efforts. They have they're generally looking to commercial payers to make up the difference from what the government's cut from them. We hold the line, as much as we can, but the reality is that's a balloon that gets squeezed, and when they squeeze the government side, the commercial side does, expand a little bit. So that is something, we work tightly with. We have like price protections within our contract with ESI, with our PBM. So we do have contractual items that protect us from some of that, balloon bubbling as well. But it will put pressure on in the future. I did see a hand raised, but I think it's gone.
I think it was from the town of Irwin, if they still had a question. Actually, my question was on the negotiating of price on prescription drugs. So Bob just spoke.
Yeah, great. And if you're buying prescription drug from us, we manage that negotiation through our PBM, and we contract directly, like our government program is one set of pricing. We're trying to align that with the CMS fee for service, commercials, commercial, and Medicaid. So that is a program we manage. As does PROAC in your case. I'll speak for Kelly and say we would love to be responsible to manage that for you.
Oh, what a surprise.
I think I saw an actual hand maybe from someone, but I lost it too. But I'll also defer to you to keep you on time management and not want to overstay my welcome.
Okay, well, thank you, Bob, for that presentation. Very interesting. I don't know if words on, I can't see the full square, but he would love that statement of you can never be over reserved. So, and I'm assuming that we can share the slides.
I got one last question for Bob.
Yes, Peter.
Because this is fascinating to me. Isn't another way of looking at this now that the Medicare space can negotiate price? It's actually not going to be for a couple of years, but that this negotiation can start to happen. Isn't it going to open the door to other verticals doing the same thing and pushing to do the same thing?
Maybe just add a little bit when you say other verticals, who do you have in
like
mind?
Regular, just non-Medicare people who aren't Medicare age.
Yeah, we do, PROAC and like us with ESI with our PBM, we do direct negotiate with our with the manufacturers, right? We contract for a single carrier. For us, that's ESI. For you, that's PROAC. Volume is king, like anything. So the same way you form a cooperative to buy health insurance and manage that risk, we do that as in partnership with ESI, where we customize a lot of our frontline work so that we feel local to our customers, but then we're part of a much larger organization that carries leverage to those with those manufacturers. So that exists today. The government did not have that authority in the past, so that is uniquely a new entity for them. We've always had that. Something unique we bring to the table, a little more salesy here, but is we have like what we refer to as market checks within our contracts with ESI. And if we see competitors getting better market rates than us, we have openers in our contracts with our PBM to go negotiate better rates. So each year we evaluate the pricing we have against whatever the most recent pricing is in the market, so we can be sure that we're always bringing the best price to the market possible based on the size of our entity. So we leverage that in the power of ESI in that space.
I mean, isn't this going to manipulate average wholesale price at some point? That's kind of where the rubber meets the road here.
Everything is off of AW. Yeah, average wholesale price is like the bottom line. Those things will alter. We do have protections in there, some price protections in there for changes in AWP. But yes, this will shake the market up for sure, and make managing that cost again on the commercial side a little bit more complex.
Thank you.
Yes.
Okay.
I'll thank you for having me. If there's anything after the fact, you can obviously work through Kelly, and I'd be happy to be available for a chat or question follow-up, and I'll defer to Kelly to connect the dots if we need to.
Thank you, Bob.
Okay. So I will turn things over to our executive director, Elin Bell.
Did you want anything shared? No. Just me.
Good evening, everyone.
and everyone present. It's nice to see people in person once again. Quick update tonight. Since we only meet yearly now, I'm going to have to fly through a lot of information pretty quickly. But first, I want to thank Excelis for putting together that presentation and working with us so effectively to pull all that together. I do want to mention that PROACT is on the line and will want some airtime to let us know how effectively they negotiate rates as well. So they are our pharmacy benefit manager, and I'm sure will be calling me after this to let us know that. And I have been sharing a lot of that information with Kylie and I recently as well. So thank you, Excelis, for the chat this evening. It's great to see you and hear from you. So I'm going to do a quick update about a year in review. We'll do a little bit more at the September board meeting. But one of the places I want to start this evening is by talking about what a fantastic team we have. And I'm not just talking about the team that's in the room with me today and the team I spend most every day with, although I will talk about them specifically in a moment. We've got great partners. The combination of the skills from Tompkins County that have gotten us up to this point with our treasurer and our IT and a lot of other resources from not just Tompkins County, but within Tompkins County, the expertise of Losi and Cahill and the members of their team, and our new representatives from Excelis, Brandon Holt, and our new PROACT representative, who have all come on within the last year or when we were dark during the pandemic, and that's Morgan Mendoza. Some of you will see a familiar face soon because Morgan will go out on a short leave and Corey will come back, but Morgan has reassured us she's coming back to the team as soon as she is able, and we look forward to that. So I'm really excited about this team. That I feel we're really starting to gel together and become solid. And I'll talk, instead of going through each area and updating each area, instead I'm going to update what each staff member is contributing to the strategic goals of the organization. So let's start with Terry, our finance manager. Terry's been with us more than a year now. She's been streamlining the invoicing process, turning it to a more electronic process, less paper driven. She is updating the rosters related to the invoicing so you know what you're paying for. She's recently introduced us to New York Class as a short-term investment opportunity and has already doubled, tripled, quadrupled our returns in just a short period of time. That's the cash that we sit on. Sits in New York, or some of the cash sits in New York Class. She's updated our investment policy, which you will hear about later from our Audit and Finance Committee. She went through her first annual audit, which went really well, and we were able to do that pretty quickly and effectively. And now she has a new challenge. She's really excited about working with the Department of Financial Services on the audit we have just been informed that we will be going through. We're going through a 5-year audit. We haven't been audited with the Department of Financial Services since 2015. And Terry just jumped at the opportunity to volunteer to manage that process. We've started on the IT side. So the county has been very helpful. We've been tapping into Excelis and PROACT on some of the services they provide to us when it comes to cybersecurity. Terry's been involved in the new member evaluation process, and she is transitioning very nicely just in time for our treasurer to retire at the end of this year. More on that probably at the next meeting. The next staff member I'd like to talk about is Kylie, our benefits specialist, who has just recently had her 1-year anniversary, although I think she feels like it's 5, because I keep telling her it's going to be slower, you know, things are going to calm down, and it never does. So I just keep reeling her in. But Kylie has been working on any plan changes and making sure those plan changes are implemented. She's been looking at consolidation and elimination of plans that we are no longer using, making sure all the coding in the system, especially the relationship between Excelis and ProAct, is working. At the beginning of the year, most of you know ProAct switched platforms. There were some bumps and bruises along the way with our employees being a little confused about some of those changes. Kylie answered all those phone calls and worked very proactively with ProAct, or retroactively maybe at that point, to make sure that system is now up and running and going smoothly. So thank you to Morgan and Kylie on that. Kylie also is working on a lot of plan comparisons for municipalities. Some, I think in this room, are looking at changing plans, looking for better opportunities on premiums and changing the way we look at how we do our benefits. And Kylie's been not only instrumental on those plan comparisons, but explaining them to employees who usually don't sit through lectures on benefit comparisons. So not only with current members, but also with potential new members, is doing a lot of that education. She's been doing plan document audits as we make sure we're compliant, always doing problem resolution for employees and municipalities. But she's also injected a lot of energy into our wellness program. We now have monthly challenges. If you're not participating, please make sure you're looking at the newsletter, the monthly updates that go out regarding wellness. And if you haven't signed up to join us on September 10th for the End to Alzheimer's Walk here in Ithaca, but there are other locations as well. Kylie's organizing that. That request came out of the Joint Committee to get more involved in community events. Kylie is the editor now on our newsletter, which is going paperless. She created a Facebook page, and that's another way we communicate with our members. You're going to hear from her later about Medicare and our supplement plan. Kylie came to us with a lot of experience in the Office of the Aging, and that's why she's probably one of the best people in the room to talk about Medicare and Medicare-related programs. Next, I'd like to talk about Lynn, who's hiding out in the back of the room and running some of the show. Lynn is the newest member of the team, has kind of jumped in with both feet. Hey, join the consortium, and we're going to do all our annual meetings in the next 2 months. So she's been learning by doing, although Michelle Coco was helpful in the transition and spent a few weeks with Lynn. Lynn's kind of learning how to ride the bike, fix the bike while she's riding it, and is doing a great job. So welcome to the team, Lynn, who continues to work on putting our meeting packets together, taking minutes at those meetings, putting the agendas together, and making sure our administration is in line and organized. So please, if you get a chance and you haven't, welcome Lynn to our team. And then the other member of our team, which you usually see in a different role, is our HR manager. So you think of her as the chair of the board, but she's just our HR manager. She's done a lot of work this year, a lot of recruiting for us. Recruiting and hiring means onboarding, training, making sure we're compliant with everything regarding the law, human resource law and labor law, civil service, my favorite topic. But she also reminds us of the important things. Take time to celebrate your accomplishments, give feedback on performance, and what improvements might be helpful to ease us in our administration. like creating a salary and wage structure to help us during the budget process when we didn't have a structure in place before. You will be hearing more about that later. So some of you are probably thinking, whoa, that team is getting really big. What are the budget implications to that? Are we reserved enough to pay for that? The budget implications continue to be less than 2% of our total expenses. So we continue to be in line and a very efficiently run organization. So, and that's the entire team with professional consultants as well. So what else is new? What other kind of updates can I give you? I can reassure you that the consortium is healthy. We are performing better than budget this year. Our income is slightly down, but our expenses and our claims activity are below plan so far this year. Everybody knock on wood. Overall, we are steady and have better performance than expected. And we are taking this into consideration as part of our budgeting process as we plan for the future, or specifically 2023. We want to make sure we are reserving, as Bob suggested earlier, at the appropriate levels. And we really want to keep an eye on future expectations that will keep our rates stable. Rate stability continues to be our overall goal. I also have in the agenda new members. We're going to talk a little bit more about new members in September. Usually I give you a list earlier than that, but we've had so much activity this year. As recently as an hour before I walked into this room, someone calling and asking about their ability to still apply. I think we're going to have 100 to 300 plus new members in 2023. So more about that to come, but our phones are ringing, and they're ringing specifically in Onondaga County. And we have to thank Mayor Olson from Fayetteville for helping us, and Lori Corsetti for helping us with that, because they invited us to a mayor and supervisor association meeting where they asked the consortium to present. And from that, I've been receiving a lot of phone calls, and Kylie and Terry have been working on a lot of plan comparisons for that. You're going to hear from committees later, but let's turn our focus a little bit back to the long-term planning that Judy spoke about earlier. Growth and the risk associated with growth, the pros and cons, the double-edged sword that we heard about earlier. Our MCA, we're going to be asking for just 2 more counties to be added to that. We still have several counties that we really aren't operating in. One new member is coming from Oswego. That would be our first member from that county. We're talking to individuals in Yates, but we're looking at a few additional counties because they're very interested in the consortium and what we're doing. During long-term planning, we are stepping back. We want to look at where we are as an organization and really where we want to be, where we want to go in the future. But one of the reasons we had Bob here today is make sure we are doing that in a well thought out process to eliminate as much risk as possible and to eliminate the adverse selection that comes along with enrolling in benefit plans. Another thing we're looking at is, I hate to say competitive, maybe it's marketable. We want to make sure we're continuing to serve in areas that other people in the market are serving. And there's been a lot of discussion recently about Medicare Advantage. Medicare Advantage, there are some groups that are really really selling Medicare Advantage plans to a lot of our members. There are other organizations coming together as buying groups regarding Medicare Advantage. And so we are looking at that as an organization. We passed a resolution recently giving the consortium the opportunity to put an RFP out to see what a Medicare Advantage plan would look like if the consortium were to offer it. That would mean offering a fully insured plan. It would not be self-funded. Medicare Advantage are lower premiums because they're government subsidized. We're not allowed to receive those subsidies. So we're looking at what would this mean for us if we offered a fully insured plan? And we really need to look at this carefully because we might lose some active members that are currently paying premiums. If a municipality, even if it's an endorsed, fully insured Medicare Advantage plan by the consortium, it might decrease our risk pool. So how are we going to balance that out if we head in that direction? It may mean additional costs to the active pool. We don't want to take that on. We want to see how we would take that on. All of these are currently being explored as part of this RFP process. Where are we in the process? All of the RFPs were just turned in. All of the quotes came in last Friday. We're preparing for this meeting today. Next week, we're going to really start digging through those quotes with Losi and Cahill, looking at what this opportunity means to the consortium so that we can bring some assessment, some evaluation, some possibilities of action at the September meeting. So stay tuned regarding that. But to help you prepare, some people I'm sure in the room are saying, what's the difference between Medicare Advantage and what's the difference between our Medicare supplement plan? How are these two different? Why can we offer a Medicare supplement plan? What does that mean? What is a Medicare Advantage plan? So I've asked Kylie to put together a presentation that she's going to share with us this evening. It's not the pros and cons of us offering a Medicare Advantage plan or the pros and cons of us offering a Medicare supplement plan. There will be a little of that, what we have to look out for, but it's really what are the difference of these two plans? And as I said, Kylie has had some experience with Office of the Aging, has spent a lot of time answering Medicare questions in her previous life. So we're glad we have that expertise and the opportunity to share this information with us this evening. So with that, I'm going to turn the reins over to Kylie. And thank you for giving me this opportunity to give you an annual update. Stay tuned. I'll probably have more to say in September.
So as we're changing speakers right now, I just wanted to clarify something that Evelyn said. She was talking about when we were talking about new members that we're bringing on 100 to 300 members. She's talking about employees and retirees.
Thank you.
We're not talking about municipalities.
Yes,
No, that would be way over.
Clarification.
So we talked about members, participants, employees, retirees, so a lot of things. So
Thank you.
sorry about that.
Okay, so just a little intro here. So I am Kylie Rodriguez. I'm the benefit specialist for the consortium. I deal with any questions you have about premiums, claims, benefits, ancillary benefits, comparisons, provider issues, network issues, travel issues, and coverage. So feel free to call me anytime or email anytime. So that's what I do now. So in my previous life, I was a high cap coordinator, Medicare counselor for Office for the Aging for 8 years. So I lived and breathed Medicare every day, talked about Medicare every day, and loved it because I'm an insurance nerd, like most people don't believe me. So this is kind of what I talked about all the time, and I taught Medicare 101 classes as well. So if you have more questions that get into nitty-gritty details and you don't want to ask them here, you're welcome to email me and call me anytime. I love talking Medicare. It's a weird thing. Okay, so starting off, a lot of people confuse the terms Medicare Advantage and Medicare Supplement, and they are very different plans that have very different coverage. So I kind of wanted to just talk about how they work and the components of Medicare. So this chart is kind of what you go by. You can't have a Medicare supplement plan with a Medicare Advantage plan or vice versa. You either choose one path or the other. You either stick with original Medicare and then you pick up all the components A, B, D, or you go to a Medicare Advantage plan, which is also called Part C. We'll get there why they messed up the alphabet, I promise. So in talking to our municipal members about why would we go with a supplement versus a Medicare Advantage plan, what are the differences, we'll dive into that component. I want you to keep this chart in mind for the rest of the presentation because it's important to understand you're not going to mix them up. The other thing to talk about for Medicare Advantage plans, which isn't as common on the main market, but we're looking at as a consortium, is whether we want a Medicare Advantage plan that houses Part A, B, and D, or do we want a Medicare Advantage plan that only houses A and B, which is medical, and then have a separate Part D or EGWP, don't ask me what it stands for, Elin can tell you, that provides the drug coverage separately. And there are pros and cons to why we would look at it that way, which we'll get into when we start talking about that stuff, but just something to keep in mind. So when and I know that some people in this room have heard this lecture before, when we talk insurance, I want to make sure we're all on the same level. We all understand the same terms and what they mean before we start diving into what benefits are for those plans. I know most of you know this, but I'm going to go over it anyway because it takes about 30 seconds. So deductible, it's the amount of money you have to pay out of your pocket before a benefit starts having coverage. So perhaps you're on a gold plan and you have to pay a $1,500 deductible, and then the coverage will kick in and cover at 80% and you pay a 20% coinsurance. But you have to meet that deductible first. Out-of-pocket maximum. This is the maximum out of pocket that you pay, and once you meet it, you're covered at 100%. I will tell you that original Medicare does not have an out-of-pocket maximum. The bills just keep coming. So that's why most people look at either a Medicare supplement plan to supplement original Medicare or a Medicare Advantage plan that has a maximum out of pocket. Coinsurance. So coinsurance is the percentage you pay for a service. So let's say you go to the doctor, I have my gold plan, I met my deductible, I'm going to pay 20% for that visit, the insurance will pay 80%. Versus a copay, which is similar to our platinum plans. A copay is a set dollar amount you're going to pay for that service. I pay my $15 when I go to the doctor. The rest is covered by insurance. So parts of Medicare, not very many people know what the different parts of Medicare are, and you don't automatically get all of them. So Part A is typically no premium. It's based on your work experience. You have to have 40 work credits, which equates to about 10 full-time years of work. Part A, then you're enrolled once you turn 65, or you can be deemed into Medicare after 24 years or 24 months on Social Security disability. Most of our members age in. So after you age in and you're enrolled in Part A, a lot of people think, cool, I have my hospital coverage, I'm all set. Part A does not cover hospitals at 100%. So you pay $1,556 in a deductible, which renews every 60 days you're out of the hospital. So you can actually be hit with this multiple times throughout the year if you keep having to go back into the hospital every couple of months. And then there are, of course, other fees. If you stay in the hospital longer than 60 days, then you have a per day copay rate of $389. And then there's other lifetime reserve days, which I'm going to be honest with you, in 8 years of Medicare counseling, I saw one person who ever hit their lifetime reserve days. Hospitals don't want to keep you. They want to send you home. They don't want to keep you for 91 days in a row. The other thing is let's say you're hospitalized under original Medicare and they send you home within 2 days and you're still not feeling well and you go back in. Well, you were sent home on day 2, so you go back in on day 3. You don't get recharged the $1,500. You're still within that 60 days of being in the hospital. So Part B, this is the part you pay for. So this is the part that comes typically out of your Social Security if you're collecting Social Security at the time. And this year's premium is $170.10 coming out of your Social Security. If you're not collecting Social Security, don't worry, they track you down and bill you. They bill you quarterly for this premium amount. So I have seen it where some people opt out of Part B. You don't want to do that if you're retired, because then you face late enrollment penalties later on. I'm not going to get into that, but you're welcome to call me if you're in that situation. So basically a thing to keep in mind for either one of the plans, the Medicare Advantage or the Medicare Supplement, you have to have Part A and Part B in order to even enroll in the Medicare Advantage or Medicare Supplement. If you don't have both, you can't pick up the other plan. The other part of Part B is it does have an annual deductible. So you have to meet that $233 before Part B will cover a doctor's visit at 80%. So another expense there as well. So you're looking at a 20% coinsurance every time you go to the doctor on original Medicare, or every time that you have an outpatient surgery or an ER visit or an urgent care visit. Part B is what covers all your outpatient care. It also covers your durable medical equipment and supplies. Most preventative services are covered at 100% of Part B, not subject to that deductible, but it depends on the service and how it's billed. So we're going to skip Part C for a minute. I know I'm going all out of whack with the alphabet, but that's how Medicare did it, I promise. So Part D. Part D is your drug coverage. Now, the drug coverage varies depending on the plan. These are averages when it comes to Part D standalone plans within the Medicare system right now. So right now, the maximum deductible is $480. So once that's met, then your coverage kicks in. Most drug plans that have a deductible at least cover tier 1 and 2 medications without having to meet the deductible. But they also have up to 5 tiers, whereas right now we have 3-tier drug formulary. So we would have to look at those differences. The average Part D premium is $33 per month. I'm not saying that's the best plan. I'm telling you that's the average. Of course, the more money you spend on insurance, typically the higher the coverage goes. So I'm not sure who's heard of the donut hole or coverage gap. If you have a senior in your life, I'm sure you've heard them complain about the donut hole. I'm going to overview it as of today. So we did sit in on a webinar. Some of this information is not going to be up to date as of next month when the legislation gets passed. So of course we may be presenting updated information as we go later into this year, but as of today, this is how it stands. So with the donut hole, typically you and the insurance combined spend $4,430 on medications, and then you fall into what's called the donut hole. And then the beneficiary would be paying 25% for their drugs, be it generic or be it name brand. So a lot of people who are on name brand medications, let's say name brand insulin or inhalers, see a huge increase in their copay rates for their medications. There are ways to avoid that when it comes to selecting plans for the consortium, such as wraparounds and other benefits, but we'll discuss that as we dive into the RFQs that were submitted. Once you reach another dollar amount, which equates to roughly $2,500 out of the beneficiary's pocket, you reach what's called catastrophic coverage. And when you reach that, your copays drop way down, and that's for the remainder of the year. To be honest with you, most people can't afford to get to catastrophic because they have to spend so much money out of their own pocket to get there. And of course, this whole cycle of Part Ds and donut holes and deductibles starts every January. So this briefly explains what, I always like visuals when I'm talking about coverage gaps and donut holes and what are we talking here for money. So this is a nice visual to look at to see where that money is coming from. So when you start out in initial coverage, really your insurance is helping to pay for those extra expenses with the medications, and you're paying your copay rate or your percentage. But once you fall into the donut hole, you see that a lot of generic would be funded by the plan, but there's also, it falls back on the drug manufacturer. Those are negotiated things that Medicare has done, which is now changing again. But it's something to look at of where that cost and coverage is coming from in the future. And then, of course, catastrophic period is where you pay that very small amount as the beneficiary. The plan pays a small amount, and then the rest is subsidized by CMS. Before I dive into Medicare Advantage, does anyone have questions about original Medicare, Part A, Part B, or Part D, which is the drug coverage? I'm not hearing any, so I'm just going to scoot on ahead. Okay, so Part C, sorry I did the alphabet out of order. Our Medicare Advantage plans. So Medicare Advantage plans, like I said, can include A, hospital, B, doctor, D, drug coverage, all in one card. But they don't supplement original Medicare, they replace your original Medicare. So the only person who's paying for any of your claims is the Medicare Advantage plan. Medicare is not going to then come in as secondary and pick up the rest. That's not how it works. Medicare Advantage plans have set co-pays or co-insurances for services, and they can vary from year to year depending on the plan, just like the premiums can. Medicare Advantage plans are more subject to networks as well. So making sure that you're going to in-network normally results in a lower out-of-pocket cost to the beneficiary than going out of network. Now, when it comes to plans like we're looking at, you could look at having the same in and out of network benefits. All of that's negotiable. But when it comes to straight on the market Medicare that people are selecting, they don't have those options. One of the things when it comes to Medicare Advantage plans is they have to match the original Medicare benefits or do better. And there's certain mandates that come down from Medicare saying you have to offer these ancillary benefits because this is what people are looking for. And then Medicare Advantage plans actually get a portion of the Part B funding to help them offer their plans to people, and it decreases the administrative costs for original Medicare. So original Medicare wants you on a Medicare Advantage because then they don't have to do most of the claims data work. Something to keep in mind, even though Medicare Advantage plan replaces original Medicare, you still have to pay that Part B premium. Otherwise, you won't have A and B to be eligible for the plan. Other things is living in the service area. Plans can vary from county to county. When you're on the general open enrollment for Medicare, the plans that are available in Tompkins County aren't the same plans that are available in Steuben or Schuyler or Onondaga or Seneca. So you really have to make sure where your providers are to make sure you're staying in that network. Let's see here, covered some of this already. The fixed copay rates, this was one of the examples that I actually took from an fully insured open market Medicare Advantage, but like a $250 copay per day for the first 5 days you're in the hospital is an example of how that's their Medicare Advantage hospital coverage versus original Medicare, which would be the $1,556 for your stay. So trying to see where you're getting the better benefit or the smaller out of pocket. Medicare Advantage plans have maximum out of pockets. So if you have something catastrophic happen, you know, okay, I'm only going to have to reach my 6,000 and then I'll have 100% coverage for the rest of the year. Or I'm only going to have to reach my 10,000, I'll have 100% coverage for the rest of the year. Original Medicare never has that. You will never cap out on original Medicare. You will just keep accruing those. Medicare Advantage plans also add on things like hearing, vision, dental. They have over-the-counter cards where you can go purchase vitamins and Band-Aids. A lot of them do meals for when you get home from the hospital. They do home delivered meals straight to your door. There's a lot of different extras that come with Medicare Advantage plans that are really a great advantage to people enrolled in them. Medicare Advantage plans can have the standard Part D drug coverage where it's subject to coverage gaps and catastrophic. But that can be avoided as well, depending on the plan. This is just, I like some of their charts a lot and I visit their website often. So I thought this would be interesting to just show the growth of Medicare Advantage plans over the course of the last 12 years to show what an uptick in enrollment has looked like. And I know in our general area, there's definitely a huge market where it comes to enrolling new providers, making sure that they have bigger hospitals and networks and things like that to be more competitive with one another. So there's definitely quite a few Medicare Advantage plan options. So how does Medicare supplement work? Well, we do know we have to have Part A and we do know we have to have Part B to get a Medicare supplement plan. But a Medicare supplement plan is exactly what it says. It supplements original Medicare. It does not replace any of your original Medicare benefits. It just picks up those amounts that I was talking about, that $1,500 when you go to the hospital, that 20% when you go to the doctor. It's picking up those amounts and supplementing your coverage. Now, there are a wide variety of Medicare supplement plans, but I'm mainly just going to talk about the ones we offer because ours are kind of the top of the line. And I'm not being sarcastic. They compare to a Plan F, which isn't even available to new Medicare eligible people. They discontinued it for anyone new on Medicare. But our plans pick up all of those balances. So essentially the person would, going to an in-network provider, see no medical bills. Medicare supplement plans also are not as restricted for networks, depending on how the Medicare Advantage plan looks, because they follow a Medicare network. So as long as someone takes original Medicare, there's an automatic crossover of claims and the Medicare supplement plan picks up the balance. So you could be anywhere in the United States that takes Medicare and you wouldn't have to worry about, are they in network with my Excelis Medicare supplement plan? They do follow Medicare guidelines as well. So if something's not going to be covered by Medicare, it's not going to be covered by the Medicare supplement plan. So this just has some tidbits about our Medicare supplement plans. So it does pick up all balances after original Medicare, and we currently offer two plans, the MS3 and the MS4. The only difference between these two plans is their prescription copays. They have the exact same medical benefits. And we do have the benefit summary up on our website as well for your review, which is just a lot of covered in full. It's there. But just to compare, the MS3 does have lower copay rates for medications. There is no donut hole that applies to this plan. This is not a Part D drug coverage plan. This is a consortium drug plan. And we recently updated in January to include a 90-day supply at retail pharmacies for our Medicare supplement plan. So you can get a 90-day fill at a retail pharmacy for 3 months worth of copays, or you can go mail order and get a 90-day supply for 2 months worth of copays. We also, at the consortium, there's riders that have been added to the medical benefits. And this is additional benefits that wasn't here for this, but the consortium decided would be an awesome benefit for retirees, and it really is, because hearing and vision are two benefits that are very difficult for any senior in any insurance to find coverage for. So these plans also include an exam, hearing aid coverage, routine eye exam, and a $100 eyeglass allowance. So I just did a quick, let's look at the big picture summary page kind of thing, Medicare Advantage versus Medicare Supplement. So Medicare Advantage typically has lower premiums, but they can vary from year to year, has set copays for most services. Out-of-network benefits depend, of course, on the contract, insurance carrier, and geographic location. ER visits are a national coverage. It's embedded, it's mandated by CMS. So anywhere in the United States that you go with a Medicare Advantage plan, you're gonna pay as if you were going in network for the ER. Prescription coverage may include a donut hole, sometimes they don't, depending on how you create those plans. But it also includes a lot of other advantages, hearing, vision, over-the-counter, home-delivered meals, a lot of things that pretty much every other insurance plan may not cover. Medicare supplement plans are typically a higher monthly premium. They are premiums that are set by the consortium. This isn't a fully insured plan. It's a plan that's the consortium created and controls. It picks up the balances after original Medicare. And as long as you're in network with original Medicare, the supplement plan will treat it as an in-network service and cover the remainder after original Medicare. Original Medicare actually has a really huge national network that travels very well, especially for retirees who want to move out of the area. Our prescription drug care plan with the Medicare supplement has no donut hole, has no catastrophic. You pay the same copays throughout the year. And it also includes hearing and vision benefits that are not standard to any Medicare supplement plan on the open market. And most of these pages are like old friends to me, but these are my references in case you wanted to take a look, go do your own research. There's lots of information available if you wanted to take a look and see what I saw. Does anyone have any questions about Medicare Advantage plans or Medicare supplement plans or how they work or what they cover?
I have one question.
Yeah.
So I know it's not contradictory, but it sounds like it at first. So when you say that in order to be eligible for the Medicare Advantage, you have to be on Medicare,
Mhm.
A and B, which means you're paying the premium, the 170, right?
Yep.
But they're not gonna cover anything.
Right.
Okay. I just
So,
wanted to be sure I had that
so the
clear in
question,
my head.
so the question was, I'll just repeat it in case they can't hear on Zoom. The question was that you have to pay for Part B, which is 170 a month, to be on a Medicare Advantage plan, but then original Medicare is not going to pay for anything. And that is accurate. So you have to pick up Part A and B in order to enroll in the Medicare Advantage plan, but then the Medicare Advantage plan replaces your coverage. The stickler point is the money value. So you have to pay your Part B, so Medicare can turn around and pay a portion of it back to the Medicare Advantage plan. And that's how they make sure you pick that up and then pick up the plan.
Yeah, okay, that's what I thought. I just want to make sure I understood it was, you know.
Yep.
Okay, thank you.
Yep. I'm just gonna.
What
check.
is our rate through the consortium again for Medicare supplemental?
The MS4 is $635.05 and the MS3 is $728, 38. Come on, Terry. Okay. 700 plus for the MS3.
Thank you.
Yeah, I can definitely get you those rates after too.
And kindly, this presentation will also be available on our website, the same as Bob's was, because there's a lot of great information here.
Sure. Yeah, I can definitely post on our website. We were going to email it out after as well to anyone attending.
So Kylie, I just have a question.
Sure.
This is the first time I've seen this presentation.
Yeah.
On our Medicare supplement, the employee does not need to have Part D, correct? So
Oh,
our supplement is in place of a Part D?
that is a great question. So our Medicare supplement provides drug coverage that is credible, so you do not need to pick up a
You don't
Part D
have the
plan.
A and B and pay the 170.
Yep.
And then our premium of 60, they had MS4, so they got 635.05. So they would pay that as their total premium with no Part D. That's their premium.
Right.
Or
So-
however it works with the employer pays portion or whatever.
So Terry's question is, if they have, on our Medicare supplement plan, and they're enrolled in original Medicare and they have Part A and Part B, do they still need to pick up Part D? They do not. So our Medicare supplement plan covers equal to or better than Part D. It's considered credible drug coverage, and they do not need to pick up a Part D plan, which would be some cost savings to someone enrolling in Medicare.
One thing we did not mention
is when you're on the Medicare supplement plan, you are eligible for retirement drug subsidy, which you can file for as the employer, not an individual. As the employer, you can file for a retirement drug subsidy. And Losi and Cahill are very helpful in helping you secure that rebate back. So Medicare Advantage are subsidized more upfront, whereas Medicare Supplement does have reimbursement, not reimbursement, subsidy capabilities that, just like filing taxes, the employer would have to file to receive that subsidy. And Lucy and Cahill have been doing a great support to our members in filing for that. And that won't be available with the Medicare Advantage plan.
Peter, do you got a question? Looks like you.
Yeah, kind of. I mean, so the drug subsidy that the employer can file for is that something that's obviously something that is being pushed out to them so they know it, right?
I think if they have questions about it, they should call Steve Losi and Cahill. You do have to have a certain number of retirees to make sure it's worth doing the subsidy. So your ones and twos retirees are probably not going to get you to that subsidy. So that's one thing to consider.
Is it like a statutory thing? Is it by law kind of have to be a certain size?
Steve or somebody else could probably answer that, but there's definitely an offset between what it costs to apply for the subsidy, go through Medicare to apply for that, it's called RBS, versus what you're going to get back.
Okay.
So there is some weighing there of cost versus
Sure.
benefit.
Okay. No, that's good information though.
Okay. Great. So thank you, Kylie. I just wanted to step back in our packet, on packet page, hopefully everybody can hear me. 4 is the resolution that Elin was talking about, clarification regarding participant Medicare age retirees in relation to our MCA. So if you want to find out more information about that, that's in our packet. Okay. Go to the speaker. Let's see. So we're going to move on to committee updates. I'm going to give a quick update from the executive committee. I've already talked about some of the long-term business planning work that we've been doing. Obviously, a lot of work on just a regular general business, everyday business. But one of the things that we will be bringing to the September meeting, which is really important, it's one of the elements that the board of directors has to vote on, which is our proposed municipal cooperative agreement. The municipal cooperative agreement pretty much has to change every year if we bring on any new members. So that's an automatic requirement from the Department of Financial Services that we update our municipal cooperative agreement. We're also suggesting, recommending 2 additional changes to the MCA. As many of you may remember, we expanded our territory last year, is it just last year, to a larger region. Through those thoughts and discussions with looking at our full coverage area and how that matches up with Excelis's area, we would be suggesting adding Livingston County and Monroe County. So that is part of the MCA revisions. The other piece, as Elin had talked about a little bit, is our treasurer that we now partner with Tompkins County is going to be retiring. And with having a full-time finance manager on staff, we will be removing the appointment of a treasurer in the MCA and under the chief financial officer, we have it delegating to the finance manager. So that's one of the major changes in the MCA. So look for those. They are in your packet, so you can see the red line version piece of that. And I think that's all I have under executive committee. I hope that everyone is looking at the minutes that come out from the executive committee and all the rest of these committees. We do send them out. They're always on our website. So please make sure that you're reading them and keeping up. I'm going to move on to, at this point, the Audit and Finance Committee. And Steve there can take the floor.
Okay, thank you, Judy, and hi, everyone. So just a quick update. We, in your packet, I think on page 28, if I'm correct on that, the committee did look over several months in discussions on the investment management policy for the consortium. And I believe at our June 28th meeting, we did approve that policy. We had obviously several discussions at the committee level on adjusting the investment policy, and all changes that we were looking at had an eye towards maximizing our return on investment and keeping risk at a minimal amount. In the end, we recommended expanding the types of investments we can use during any particular year, all which are permitted under general municipal law. And we did update the investment parameters to limit the risk of loss. And we did increase the risk just a bit to allow our investment manager, which currently is Williamton Trust, gives them some more flexibility as we look to increase our investment returns. And of course, all of this is very timely due to the current increasing interest rate environment that we have. So we do expect to continue to increase our returns and investments over the next year as interest rates continue to increase. So I believe that investment policy with its updates is in the packet on page 28, and I believe the red lines in there will reflect the changes that we did make. And we'll be bringing this to the September meeting for approval. In addition, of course, our most recent discussions over the last couple of meetings have been discussing the 2023 budget. And Judy, I don't know if, obviously we have a presentation in the packet, but is Paul or Rob going to do a detailed presentation on that, or how are we handling the budget itself?
I think, Paul, are you doing that?
I'm here. I didn't know if you wanted me to go through a full thing or just kind of give a brief overview of the budget document. Again, it was included in the packet, but I certainly can just give you some of the highlights of what we're looking at moving forward into the 2023 year based on some of the financial information we have to date. I don't know if you want me to share a screen or if you all have access to it.
I think we're going to, Paul.
Okay, thanks.
We'll pull it up, and I think, quick review
Just-
on where we are.
Oh, yeah.
Yeah, brief.
I'll just hit the highlights and we'll try to move through it pretty quickly.
What everybody's been emailing and calling me about is premium. Let's get to the premium speculation part.
Okay. So when you pull it up, why don't we just slide right to slide 22? So hopefully that gives you a little bit of comfort. Presentation slide 22 anyways, that is, not in your packet. Because this is just initial budget information of where we are the current year. And if you want to just talk budget for next year, let's move right to that. Okay. What we're projecting for next year, and we still have a little bit of data to get, so there may be, a chance for a little bit of wiggle room, but we're trying to be conservative at this point. Currently in the 2022 year, we have had a 5% budget increase. And that strings together a lot of years. The last 4 years have been 5%, and before that, 4%, 5%, 3%. Next year, right now, we're looking at a 6.5% increase at the current time, just based on our projected claims. And I'll get into a little bit more of that in the next one. A couple of the factors that are driving this right now is we're hoping to improve our RX rebates and our interest earnings. Those numbers, if they can move a little bit, that may help the projected budget on the premium side. Again, we're trying to be conservative at this stage of the game, with another month of data before we try to finalize the budget. And as you talked about in the reserve fund presentation, the chances of large losses coming in. We are through July, like Evelyn said, knock on wood, we're in great shape right now, but 5 months is a long way to go with a group this size. Let's go to slide 23, please. These are really just outlying years, and you shouldn't really get too focused on the 7%. When we build our budget models, we try to look 5 years out into the future and keep it in mind all of our budget goals that the board has established. And that is funding our reserve funds at a certain level, as you talked about at the beginning of the meeting. And then also, at the end of the year, what we'd like to have an undesignated fund balance, and we'll touch that a little bit later. Let's move to the next slide, please. We can roll up right up to the next expenses. There we go. Yep, keep rolling. Slide 28. So as we look at where we are at the amended budget, and you're going to see something that looks kind of peculiar. You see the amended budget for 2022, we had $40.7 million in projected claims. And next year's budget, we're actually almost flat. And that's why we're a little hesitant right now to bring that 6.5% down. We are having a great claims year right now on the medical claim side. COVID has skewed things a little bit over the past few years. So what we've done, we've trended our expenses basically at 4.75% for next year and out. But we did try to look back and kind of take COVID out of the picture somewhat to say, which has been hard to do over the past couple of years. So right now, we're pretty comfortable with that 40.7 million on the medical claim side based on where we are through July 31st. RX claims, we trended 7.5%. That's running pretty true, and it has all the way through COVID. So that's we're going to trend that at 7.5% all the way out for the outlying years. And again, keeping in mind that that's a 6.5% premium increase rate right now that's supporting that. All of our other fees are very nominal increases, 3% like on your medical admin fees, 5% on your taxes. We trended the stop loss insurance. We used to budget 15% increases for those, but now we're going to budget a 10% increase. And you're going to notice to the left side actual results of 270,000. That's because, like you heard in the earlier presentation, we budget for $1 million. We actually purchased $1 million deductible, which is much cheaper than a $600,000 deductible. But we budget for the $600,000 deductible. That gives us two things. That gives us a little bit of wiggle room in the budget should claims exceed itself. And it also serves as a funding mechanism for our catastrophic claims reserve that they talked about. We take the savings between the premium, move it into our catastrophic claims reserve, and those claims that come in between $600,000 and $1 million, we pay out of that reserve fund. So we hope each year that kind of offsets itself, and it keeps us on solid ground so we don't have to increase that reserve fund or buy a lower premium stop loss policy. Next slide.
I'm going to stop you for a second there. I also want to point out to folks that in the actual, it's 270,000. We budget for it at the 700 because if in any year the board decides that we need to go back to a plan that is only a $600,000 deductible, we're not going to give you a sticker shock because we're adding $500,000 in this line.
Correct. Great point, Judy. Okay, and again, the claims, the medical claims and the RX claims, that is the vast majority of the budget. But some of these are the other nominal items, the salaries for the staff on hand at Tompkins County, insurances, consultant fees. The one thing that's highlighted there, you do see the DFS, they want to audit you, but they don't do it for free. They actually do bill the consortium. which is kind of a unique thing. They kind of dictate the number of hours and the rate, and they send you bills for auditing you, which is a kind of a crazy way to do things. But so we budgeted 150,000 for 2023 and 150,000 for 2024. These type of audits tend to drag on. Some of that money could actually shift into 2022 if we get invoiced for it, and maybe it won't get out to 2024. But right now we're budgeting 150 for both of the years. So when you look at next year on the expenditure side, we're looking at about $62.8 million on the expenditure side. And if you could scroll through the next slide. Okay, and this is just the outlying years. Again, you're going to see the growth of the claims at 4.75 and the medical or the RX claims 7.5. Everything trended as we just spoke about. You can move forward. And let's go to slide 33, please. When we talk about trends, we look at a couple of things. So we tell you that we budgeted Greater Tompkins County of 4.75%. If you look at the history of Greater Tompkins County going back to 2011, the trend for this group has been 4.256. So yeah, you want to hit the trend line, but you also want to be conservative. 0.5% above that trend over this long period of time, we feel is a good place to be, especially with the history you have going this year. If you go to the next slide. And for the Greater Tompkins County on the RX side, we budgeted 7.5. The claims trend for this group is 5.7%. And you look at recently, it's really right on the trend line. I mean, it couldn't be almost more on. You got a couple little blips, around April 2020, but not a lot. It's pretty much right on that 5.761 trend line. And then what we do while we're budgeting, if you go to the next slide, please, we also keep in mind our whole book of business, all the different school groups, the municipality groups that we're working with. And you look at the claims trend for the whole group, again, you see where COVID-19 was, it definitely dropped below the line. So we try to keep that and take that out of play. That skews that trend line a little bit. So you see our whole book of business at 3.7% roughly. And so we're feeling really comfortable with the 4.75 trend on the RX claim. Where we're trying to be conservative, yet keeping in mind that we have to hit certain budget goals, maintain moderate premium rate increases, and try to hit our fund balance, reserve fund, and unencumbered balance targets. If you go to the next slide. And on the RX side, you'll see that the claims trend for all of our groups, 6.9%. And so we're thrilled that the 7.5% is a very fair percentage and should keep the consortium in good, solid financial shape. And let's roll right now to slide 48, please. All these other pages in the package, they give you the definition of our reserve funds and where we are, but this is where we look to be on the outgoing years. If you look at the projected budget, one of our budget targets annually is to again, for emergency situations, should we have a bad claim year, is to retain a certain amount of unencumbered fund balance. But as our claims grow and as our premium grows, you'll see that the IBNR, the surplus account, those reserve funds are going to grow as they're a percentage of those numbers. So as our reserve funds are growing, you'll see that our target for our unencumbered fund balance is always 12%. 2023, we meet that target. 2024, we virtually meet that target at 11.97. And then we dip a little lower, but then we start to make the rise back in 2027. And again, that's 6.5% this year, 7 on the outlying years. Again, based on experience as numbers come into focus and we have some positive results, these outlying years can certainly change and be modified. Again, we're really focusing on 2023 right now. We're going to update our presentation for the board in September. We'll have all of August information in, so hopefully there might be a little bit of wiggle room in it for next year. But right now we're at the 6.5% on a projection for 2023. Any questions on that? I know I kind of breezed through it pretty quick. Anybody feel free to give me a shout, or Rob or Steve. If you go through the presentations and you got a question on a particular slide or anything, I know in this forum, I'm really trying to rush through it, but I don't want to shortchange anybody. So if you have any questions, I'll be happy to answer.
Thank you, Paul. And one of the things that we're also going to have to, take into consideration as we start next year is our new members, how many are coming on, how that changes our premium income and our expenses. So
yeah, that's a great point. This presentation is based on current population and the plans they're currently in. So we will need to adjust and amend the budget based on any new groups, hundreds of peoples that come in, be it not hundred of groups.
Yes. Thank you. Steve, do you want to add anything in addition?
I don't think so. Just quickly, we'll have one more final discussion at our September 13th committee, the Audit and Finance Committee on the budget. So we'll get the latest data at that point and hopefully come up with a good recommendation to the board at obviously the September meeting so we can approve the budget for next year. So otherwise, I think that's it for me.
Thank you. At this point, we're going to go on to the Operations Committee for an update from operations.
Yeah, Lisa is unable to join us tonight. Her alternate is with us, Ruby, but Ruby doesn't sit in on operations, so I'll fill in for Lisa. Operations Committee, there's nothing in front of you, but the one thing the Operations Committee is really looking on is plan involvement going forward. How many plans can a municipality elect to have if they're a small municipality? How many plans can a large municipality? Because we really want to move away from adverse selection. So we don't want to give a small group 2 options and all the healthy people go into the less expensive option and all the sick people go into the more expensive option. So we don't have healthy people supplementing the sick people. Also, we have some really outdated plans that just keep sticking around and sticking around. And so we're looking at a very fair way, a long-term way that we may cull down our plans to make it less cumbersome administratively and give a runway for people to move away from some of these older plans, not have employees be able to jump out and jump into them. Those are discussions that are going on at operations and joint committees and other the executive committee level. So nothing has been decided on that, but we do keep having conversations related to that. The operations committee is also very involved in making sure we're compliant with our Department of Financial Services, our business continuity plan, our cybersecurity plan, which is a very big part of this IT audit, and has also been looking at helping us streamline some of our other policies, our application policies, and some things we just have to keep looking at from year to year. So there's no action that will probably be coming before you from the operations committee in September, but we are going to keep working on some of those policies. We also put in place a wage and job scale. I don't know, we probably don't have time to go into detail on it, but the wage and job scale is very similar to coding within civil service. I don't know what the right words are. Coding positions within civil service. So we have job descriptions outlined and then a salary structure supporting that. So we're not sitting at audit and finance meetings or board meetings and saying, hey, how much do you think we should pay the executive director next year? It's mapped out now. And that went in front of the operations committee. So with that, I think I will move to the Joint Committee on Plan, Structure, and Design, where I am also giving the update for Jimmy Bauer. The Joint Committee is making a recommendation on page 136, I think, of your packet, 132 of the packet, in that we will, based on the calculations for the actuarial value calculator the one plan that fell out of the parameters of our plus or 2- standard deviation was the silver plan, which means there will be adjustments needed to get the silver plan back into compliance. And the recommendation from the joint committee, which is on page 132, is to move the deductible, increase the deductible by 250 and increase the out-of-pocket maximum by 1,000 for single. And this is in network. And then increase the deductible for family by 500,000 and the out-of-pocket family maximum from 12,000 to 14,000. So those are the changes to deductible and out-of-pocket maximum. There's also recommendations on out-of-network, but as an enhancement to the benefit is also changing the co-insurance level. The co-insurance is currently 70% on the silver plan, which means an employee pays 30%. With this change, the co-insurance would be covered at an 80% level, which means the cost for an employee would go down to the 20% level. So those are the silver plan recommendations. That gets us into 71.83%. We think that'll hold us for a year or two, so we don't have to change this next year. And those will come before the board in September. The other thing that is changing on the next page is the standard deviation for the bronze plan. The bronze plan in the actuarial value calculator put out by the Centers for Medicare and Medicaid Services. The bronze plan has been wonky for the last couple of years. And this year they have made a recommendation that instead of a 2 ± standard deviation, that for the bronze plan, we move to a 0.5% and remain the -2%. So from 65.49% to 57.50% to remain in compliance for the bronze plan. That would keep us compliant. We wouldn't have to change the bronze plan this year, but we do have written policies of that standard deviation of just 2 ± 2%. So the recommendation will come to change that standard deviation. So those are the two recommendations coming from the joint committee forward as we look at the actuarial value calculator and the feedback from CMS.
So we'll move on to, thank you, Eva. We'll move on to nominations and engagement committee. Ed?
I'm on board here. Elin, jump in anytime to help me with this, but from what I'm seeing in the packet, I was not able to make our last meeting. There's only 2 vacancies, and those are in nomination and engagement committee. There's one for labor and then a open position on there. I just encourage everybody to please, it's a great thing to do. These are phenomenal people to work with. Elin keeps us on task, and the meetings are not that long. In that, volunteer yourself, or if you have somebody in your municipality that can, get a hold of Elin or one of the people in the consortium to join and get into it. It's very rewarding. Elin, anything else?
So what will come before the board in September, we do approve officers. There is a little change up in officers. And I think that resolution is in the packet, but if you look at page 134, you will see the lineup of officers. Judy, after a million years, 8 years, is stepping down as chair, and our vice chair, Warden Hart, has agreed to step in. The vice chair nomination is for Lisa Holmes to move into that position. So that means some other chairs will change as well, but we do have to approve the officers. So that would be Warden Hart, Lisa Holmes. Our CFO will remain Steve Thayer, and that is outlined in the MCA. And our secretary would be Peter Salton. The other seat changes, some will happen is operations chair will be Laura Granger. We'll get some representation from Seneca County on our executive committee. We are recommending from Cortland County that Mayor Steve from the city of Cortland fill one of the at-large positions. And there is a clause for the past chair to sit on the executive committee. So Judy Drake. The other members of the executive committee, Ray Bunce, Ed Fairbrother, Bud Shattuck, Eric Snow, and Gary Muchler would remain on the executive committee, either because they're at large and still able to serve, or they are a chair of the committee.
Okay, so in your packet on page 134, highlighted in yellow is where some of the changes are going to be. The joint committee, you'll see under the executive committee is vacant. The joint committee decides on their own chair, and Jim Bauer has given notice that he's going to step down as chair and not go for re-election, reappointment, whichever way you want to say that. So the joint committee will be establishing their chair. So that's up to them. So as Ed said, we do look to fill some of the vacancies, and if anybody is interested, we certainly love to have new people on the committees. Last year, we did put in some term limits, so we are going to need some people to step up as time goes on. A lot of the people who have been serving on some of these committees have been serving on them for years and keeping the organization running. So it's really important for board of director members to step up and get involved. So we'll move on to Bud Shattuck for Claims and Appeals Committee.
Yeah, okay, checked out. Okay. There's nothing huge for claims and appeals, no appeals. And we did our prescription drug audit this year, and that was uneventful. It was a pretty straightforward audit. So there's nothing huge to report at this meeting. Okay.
Loveland Claims and Appeals doesn't have a lot of work, so that's a great committee to serve on. Okay, so that comes to pretty much the end of our agenda for tonight. Does anybody have any questions or feedback? We are running a little bit late, but we had some great programs. Any last minute questions? Rick?
Judy, I would just like to say goodbye to the group. I plan on being here in September for the board meeting, but I have a budget meeting that night with our legislature also. So there's a bit of a conflict. I'll try to do both. But I want to thank everyone for allowing me to be your treasurer. It's been a great 9 years here with Tompkins County, and I have full faith in the employees and the workers that you've put in place with the Health Insurance Consortium. I know they'll do a great job. I just wanted to, if I don't see you at the September meeting, I wanted to say thank you very much for allowing me to serve and wish you all well. my last day will be on November 29th. So I wanted to thank you very much.
Thank you, Rick. We really appreciate everything that you've done for the consortium over the years, so. And we know it was thrown at you. Didn't know that it was part of your job probably when you took it with the county.
I did not.
Other duties at the time, we loved them in the HR. Okay, so just as a reminder, our annual Board of Directors meeting is September 22nd. It's at 5 p.m. It is at TC3. We would love to see some people join us. Hopefully those that joined us today will continue to join us. We do have snacks, so that's always a great incentive. It is the meeting that is extremely important to the consortium as we vote on our officers, our premiums, any plan changes. So it's an extremely important meeting, and we hope that everyone will participate in that. Otherwise, thank you and have a great month.